Okay, so good morning. Today I will speak about a clinical approach to dysautonomia and small fiber neuropathy. I have no disclosures. So the outline of the talk is this. I will talk about an approach to dysautonomias. Then I will talk about the bedside autonomic testing and the objective autonomic testing, and then about small fiber neuropathy and small fiber neuropathy, neuropathic pain treatment, and a study that we are doing right now. Okay, so for dysautonomia is a term that includes any disorder of the autonomic nervous system. I created this chart to basically have a practical approach to dysautonomia. So the first thing we do is clinically assess the autonomic functions. So we do it via clinical autonomic testing, and I will speak about those later. When the suspect of dysautonomia is confirmed, we have to exclude mimickers and then to understand if it's a syndromic case of dysautonomia, so for example, POTS, or the lesion is central or peripheral. In the case of central lesions, for example, we can have dysautonomia in the context of Parkinson's disease, MSA, or pure autonomic failure, but we can have it also in multiple sclerosis or in traumatic brain injury. So these are some of the mimickers of dysautonomia. Many medications can mimic dysautonomia, but also pheochromocytoma, adrenal insufficiency, thyroid disorders, anemia, structural cardiac disease, weight loss, and chronic volume depletion, giving rise, for example, to orthostatic intolerance. So once we know that it's a peripheral cause of dysautonomia, the next thing is to objectify the findings. So we can do objective autonomic testing. And then once we confirm the peripheral etiology of the dysautonomia, we can consider chronopathology. So we basically use localization first, and then the chronopathology of disease. So we can get some hints about the etiology, and we do laboratory testing. So how can we assess clinically for dysautonomia? There are some tools that try to help clinicians assess symptoms of dysautonomia, and the most used is the Compass 31.
Laptop.
Sorry? So the Compass 31 has 7 domains that you can see here, and is useful, for example, when we have disease-modifying treatments to assess periodically the symptoms of the patient. But a practical approach to autonomic history is this one that I modified from Goldstein, Principles of Autonomic Medicine. So we basically reason based on the system. So sympathetic cholinergic function, we can monitor that, asking the patient what, like function, we can ask if the patient has issues standing still. So basically the orthostatic intolerance symptoms. And then parasympathetic cholinergic function can be tested, asking for spit and tears and the GI system motility and function, urination. And if the patient is a male, we can also ask about erection and ejaculation. Many of the orthostatic intolerance symptoms arise from the fact that basically the blood flow to the brain is reduced. And one strange symptom that can arise as well is the cot hanger phenomenon. In patients with orthostatic intolerance or orthostatic hypotension, standing upright can result in pain in the neck and shoulder. And that's probably due to the fact that the trapezium and the neck muscles that have to sustain the head receive less oxygen, less blood. But we have other signs that we can detect while we clinically assess a patient with dysautonomia. And for example, there are some dermatological signs. So for example, the Raynaud's phenomenon, livedo reticularis, erythromelalgia, or urticaria should rate the suspect of dysautonomia. Here are some pictures of Raynaud's phenomenon on the right, livedo reticularis on top. And then we can also have acrocyanosis with prolonged blanching after fingertip pressure. These are two pictures of erythromelalgia in the feet and in the hands. Also, some patients with POTS can have a history of joint hypermobility. And in order to test that, we can use the Baton scoring system. We can ask the patient to do the movements that you see in the picture, and we can score that in order to have a more objective assessment of joint hypermobility in these patients. Another thing that you can also clinically monitor is the photoresponse to light. Addis pupil or tonic pupil is the sign of near light dissociation. So the eye doesn't respond to light, but it responds to a near target. Two tests that we can do to practically assess autonomic functions are the Shellung test and the spoon test. The Shellung test here in this paper is presented as a heart rate changes monitoring in German-speaking countries. It was proposed first by Shellung, and many people do it in different ways. The way I propose it is the same as in this paper and the way I do it. So you basically ask the patient to stay, to lay down for 5 minutes, and you take the blood pressure. And then you ask the patient to stand up still for 5-10 minutes. It depends, because geriatric patients may have some problems standing up 10 minutes, so you want to do it for 5 minutes. But if you have younger people, you can do it for 10 minutes. Sometimes with POTS, it takes some time to detect a significant heart rate increase. So in the upright posture, you take blood pressure and heart rate, and you can do it with the pulse oximeter every minute till the 5 or 10 minutes. This way, you can monitor heart rate and blood pressure. For example, you can detect POTS, which is diagnostically defined as a heart rate increase of more than 30 beats per minute. But we have to remind also that if we deal with a patient who is younger than 19, then we need an increase or more than 40 beats per minute. And also, POTS is defined by the absence of orthostatic hypotension. The spoon test is a useful test, bedside test, that we can use to assess sweating in patients. The room must be actually pretty hot, but the way it is approached is that we use a spoon on the convex side, and we move it on the skin of the patient. If there is anhidrosis, the spoon will quickly go without friction. But if there is some sweating, then the spoon will encounter some friction. And this is the paper that presented the spoon test. Okay, so once we know that it is we have a suspect of dysautonomia, we can also do some autonomic objective testing. How do we do it? We can do the tilt table test. The tilt table test is a test where the patient is tilted. So a gravitational challenge is applied on the patient. And we can see the heart rate response and the blood pressure response. So as I told you, in POTS, there is an heart rate increase of more than 30 beats per minute. But the blood pressure, as you see here in the picture, stays pretty much the same. We have also other patterns that we can encounter both in the Shellung test and in the tilt table test. So reflex syncope, what happens in reflex syncope is that blood pressure and heart rate suddenly decrease. In orthostatic hypotension, the heart rate can increase a bit, but the defining feature is the decrease of the systolic blood pressure by more than 20 millimeters of mercury, or the decrease of diastolic blood pressure by more than 10 millimeters of mercury. Then we also have the Valsalva ratio, where we calculate the aortic pressure and the heart rate in response to the Valsalva maneuver, and the deep breathing test. The deep breathing test is based upon the fact that when we breathe in, our heart rate increases, whereas while we breathe out, our heart rate decreases. So that's a normal response that you can see in the slide. Then we have two pseudomotor testings. So we have the QSART, the quantitative pseudomotor axon reflex test, that, as you see, quantifies the sweating activity in all the limbs. So for example, here you can see a decreased sweating activity in the foot. And also we have the thermoregulatory sweat test, the TST, where you can have different patterns, and those can basically help you determine if it's a central or peripheral cause. And in fact, you can put together the results of the QSART and the TST to tell if the disease is more peripheral or central. The QSART evaluates postganglionic function. So it is abnormal when the lesion is peripheral. Whereas it will be normal in a patient with a central nervous system cause. So for example, in TBI, the example I propose here is neuropathic POTS versus postconcussive POTS. So the pattern of the heart rate and the blood pressure on the tilt table test will be diagnostic of POTS, but then we can also subclassify it and understand if it's neuropathic. If it's neuropathic, the QSART will be abnormal, or if it's a central cause. So for example, in postconcussive patients, and the QSART will be normal in that case. So small fiber neuropathy, I present here a case, a 62-year-old right-handed male that presented to our clinic with a chief complaint of headaches. The patient had a history of syncope, and in fact, he fell and hurt his head, and he was diagnosed at the hospital with a subdural hematoma that caused his headaches. The patient recovered, and he had no residual symptoms actually. We later saw the patient, and he presented to our clinic with another chief complaint, which was tingling and pain in his feet. We took the autonomic history and we did some clinical autonomic testing. And these tests showed marked bradycardia, a history of IBS. He also had dry eyes and feet hyperhidrosis. The neurological examination shows decreased pinprick and temperature sensation in the feet. So these findings are suggestive of small fiber impairment, whereas vibration and proprioceptions, which are due to large fibers, were normal. And indeed, strength and reflexes were preserved. The EMG and ENG studies, which detect a lesion in the large fibers, were normal, as it should be in small fiber neuropathy, and the objective autonomic testing in skin biopsy confirmed the definitive diagnosis of small fiber neuropathy. So if we go back to the approach I presented in the first slide, here we assessed clinically the dysautonomia of the patient. We then assumed that it was a peripheral cause because he had tingling and burning pain in his feet. So the cause was peripheral. And then we did objective autonomic testing. We can also consider the chronopathology of disease. So for example, this patient had a subacute onset of symptoms. So we can think about paraneoplastic or autoimmune conditions. In this case, he had dry eyes, and we tested for SSA and SSP. So we have some clues that can help us do a first year of laboratory testing in order to understand what's the etiology of the systemic disease that may underlie behind small fiber neuropathy. So these are the symptoms. Small fiber neuropathy patients present with sensory system symptoms, autonomic symptoms, isolated sensory symptoms, isolated autonomic symptoms, or mixed sensory and autonomic symptoms, like in this case. So the usual sensory symptoms are burning pain with usually stocking glove distribution. Evoked pain, many patients have allodynia and hyperalgesia. They can have pruritus, paresthesias, dysesthesias, hyposthesia to thermal and pinprick. sensory function, and they can have also restless leg syndrome. And then we have many autonomic system symptoms. So the pattern of these sensory symptoms is, as I said, usually stocking glove pattern. So just the distal extremities, the hands and the feet initially. But actually, small fiber neuropathy can present as a non-length dependent SFN. So it can have a patchy distribution, and it can affect the limbs in a non-symmetrical way. These are many of the causes that we have to take into consideration. So one of the most common causes is diabetes, of course, but we have also to think about vitamin B deficiency, B12 deficiency, other autoimmune mediated cause. So for example, SLE or Sjogren's syndrome. We can also consider MGUS. We've had a lot of patients with MGUS polyneuropathy, paraneoplastic syndromes, and then also infections. Some drugs can cause small fiber neuropathy as well. And we can have also hereditary causes. I want to point out that also in neurodegenerative conditions, we can have small fiber neuropathy. So for example, there's been evidence that in Parkinson and even in ALS, there can be small fiber neuropathy. Okay, so the way we approach the laboratory testing is to get a clinical sense, assessing the chronopathology of disease, of what can be the cause of the small fiber neuropathy. And then we decide what are the studies that we can do as a first year. These are some ideas based on the most common etiologies. So we, of course, check for diabetes. We can check for SSA and SASP. We can check for vitamin B12, etc. Of course, some tests, for example, celiac disease testing, will be done if there is an evidence, clinical evidence of celiac disease. And then we have other tests that can be done, and even genetic studies that can be done if the cause is not found. Okay, the diagnosis is confirmed by skin biopsy. As you see in these confocal images, the skin biopsy is usually done on the leg. And here you can see the biopsy of a patient with small fiber neuropathy secondary to HIV infection. So in the first picture, you see in red the fibers, and in green the basement membrane. And you can see that the arrows point to the fibers, the red fibers that cross the dermal epidermal junction. But in the patient with small fiber neuropathy, as you see in picture B, you don't have fibers that cross the dermal epidermal junction. So the density of the small fibers is decreased. So how do we treat the neuropathic pain in small fiber neuropathy? The main medications that we use are anticonvulsants, mainly gabapentin and pregabalin. The most common side effect is drowsiness with gabapentin, but we can also use duloxetine, and we can use topical anesthetics as well. So for example, lidoderm, we can use patches and cream, and also compounding cream, capsaicin cream. I now will present one idea that we had in the study that we are pursuing with Dr. Bernard. So there's been evidence that low-dose naltrexone is useful in chronic pain syndrome. So for example, it has been used in fibromyalgia. It has been used with success also in multiple sclerosis and inflammatory bowel conditions. So my idea was to try to use low-dose naltrexone in patients with small fiber neuropathy. So the way low-dose naltrexone works is that at high doses, it works the way we know it. But at low dose, it has a paradoxical effect, and mainly works by modulation of the glial cells. So it works basically on the inflammation. It has been shown that it also has an effect on the opioid receptors, so it can help with the pain, and indeed it has worked in some patients with fibromyalgia. Where do I see what's the possibility, or where can we use low dose naltrexone? We can use it, for example, in patients that have failed multiple neuropathic pain medications, so we can try low-dose naltrexone. But we can use also low-dose naltrexone in patients who are going to do IVIG as a last resort, as a last medication resort. So I don't know if it works, so I don't want to express myself on low-dose naltrexone in small fiber as it is for now, because we are doing some studies to assess if low-dose naltrexone can have a role in the treatment of neuropathic pain in small fiber neuropathy. But it seems promising. We have also tried to use it in patients who are using gabapentin, but gabapentin doesn't relieve all the pain. So we want to know if low-dose naltrexone can improve the effect of gabapentin as well. Thank you.
Okay. Let's stop